I'm Dr. Bruce Johnson. This is just a quick rundown on a case where we're trying to demonstrate how important it is that we tag team in certain kinds of situations. And one of the things that Dr. Gerardo and I found out very early on when we first started working together was that cases that were really problematic for me, cases where people like never stabilize on an orthotic or something like that, or we had trouble getting the joint to stabilize, his activities would make my job a lot easier. I kept thinking it was my orthotic was needing another adjustment, and the reality is that they needed that belt or something like that. So, so this is just a case where not a start to finish type thing, but this is kind of a hiccup that happens sometimes in the process of treating when you're orthodontically moving teeth around. Even if you have an orthotic in the mouth, changes can occur that results in things kind of go in the wrong direction, and that's what happened here. Originally, this is about a closed lock case, but the case actually is a snoring sleep apnea case. Okay, this gentleman, who's as you can see, is pretty tall, basketball player, in the past, or anything, pretty good sized guy, and he had been on an APAP, a variation on a CPAP machine for a number of years, and it was just getting pretty old having to strap this thing on his face every night, and so wanted a solution that such that he didn't have to wear that any longer. And so he got referred to me by one of the myofunctional therapists that I work with, and who I work with quite a few of them, one of them who's sitting in the audience here. And so an assessment was done. Sorry, trying to find the right button. That where we look at things like oral volume. Okay, is there enough room for the tongue? Okay, mandibular position, is it retrognathic and carrying his tongue back into his throat? What are the reasons for him having sleep apnea? And is that something we can do something about? And we felt yes. And so we proceeded to get involved with getting him on an orthotic to help with the mandibular repositioning, get him into the appliance, which you heard a little bit about from Dr. Gerardo this morning, and to get some arch development going to improve oral volume. Okay, I feel that's one of the major reasons why people that have the bicuspid extractions have so much of a problem, is that all of a sudden they're suffering from a tongue that's too big. And of course, we know it's really the mouth that's too small, not the tongue being too big. So we went to work on that. And one of the things that happens when you start expanding the arches is that it's, for those of us dentists who have worked with any kind of orthodontic appliances, keeping the upper and lower arches in sync with each other is really difficult to do. And so the result was, during the process where we're up here doing arch development thing, he walked in one day, and I think we were 3 or 4 months into treatment, something like that, and with a closed lock situation. So now he can't even open his mouth. And his was so severe that usually when we have a unilateral closed lock, that's when David was talking a minute ago about this deviation and deflection type of issue, because one works and one doesn't. They'll deviate off to one side or the other. I mean, he wouldn't even deviate. I mean, he was locked, but the one joint did have range of motion. So this is a situation where I know that we need to tag team together to get chiropractic adjustments done. Okay, and he needs occlusal support, and cranial. Well, obviously, I mean, when you're working with an SOT chiropractor, it's all going to be cranial based. So, having worked with Richard so long, I don't even kind of think in those terms anymore, because. But I have to remember that not all chiropractors, have an osteopathic, basis for the treatment they do, and which is one of the reasons why David made the statement he did. And I'm not quite as hard-nosed about that as you are, but I tell him I'll try working with your chiropractor. If you come with a chiropractor that you're comfortable with, I'll try working with them. But I'd say 9 out of 10 times, I'd tell them, okay, it's time to change boats. This teamwork just isn't working. Because number one, they don't understand what I'm doing. They don't understand the language. Even I'm really not, eloquently, speaking the SOT language as all of you will. But I know enough within a couple of minutes talking with them that that this is probably not going to work. But anyway, so we went to work, and these are cases where when I send him to him, then Richard and I usually talk on the phone, or because he's in my office regularly, we'll take a few minutes before he runs out the door, because he's always late for something, and so you have to know Richard. So anyway. More often than not, he's running out my door. He's also usually running in it when he gets there. So, anyway, I think a few months of working together in combination with doing some prolotherapy as well, and it was interesting that as we worked along through, I'd say probably somewhere in the second or third month, there was just a change, a noticeable change in what he was feeling. He was still locked up, but he was not as uncomfortable and stuff, and it was starting to feel a little bit different, even in my hands, who, I'm not a chiropractor, and so I don't feel things. I wasn't trained as a chiropractor, but in my limited abilities, I could tell something was changing, and then all of a sudden, even as well, Dr. Gerardo, mentioned that something different was happening, and then a month later he walks in and he goes like that, and the bubble broke. Yes.
Yeah. Do you remember? Was one side of his jaw very swollen also?
I don't recall there being any. The question was there swelling, and Richard is shaking his head no, and my recollection is no.
You're the dentist, so you know when to do the prolotherapy. Do you ever do it when the tissue is swollen, or you have to wait till it calms down?
Okay.
Repeat the question.
Okay. So the question was about the prolotherapy. Do you wait until the swelling is gone, or is there any timing with that? Actually, Dr. Gerardo generally is the one that instigates the message that says, okay, I've got them to this point, let's do some prolo, and because I'm really at that point doing prolo to supplement what he's doing more than what I'm doing, because he's the one that's doing the manipulation work. I'm providing just support. What? No.
Can you repeat the question?
He was just stating that I don't inject into an inflammatory joint. No, you don't want to make it worse.
Exactly.
Yeah, I don't remember when we started that, but obviously that wasn't happening. That wasn't like the first thing we did. Okay. And so as of just a few weeks ago, he's now opening to 55 millimeters and has no pain, no dysfunction at all, and that rotational path, translational path is nice and smooth and clean again. So now we're back to work, and I don't know if we had anything else. So the following month, just to make sure he was healthy and sound, we went back to resetting the bite again after being adjusted by Dr. Gerardo. We went back, reset the position on his orthotic again, and then went back to work with his alpha appliance. So his appliances now are a lower, what's called an omni in the ALF terminology, and basically an omni appliance is kind of a combination of an alpha appliance, so you can do arch development with it, but it has occlusal coverage on the posterior teeth, so you can maintain some semblance of maxillomandibular relationship with it. And again, that's kind of what happened earlier on, is that, like I said, it's difficult to keep those two in exact sync all the time, and if they get out of sync a little bit, you can precipitate an episode where he locked up. The good news is that's pretty rare. I think that's the first one that I can remember in a long time. Yes?
Did you do a sleep study before and after on this man, or no?
He arrived with one. Okay. It was asked if he had a sleep study done, and yeah, he had all that prior to coming to see me.
Right.
Yeah. And of course, we have our own system in the office now, and we will run that at some point in the future when it's appropriate. Yeah. Yeah, we're kind of wanting to get back into his original treatment, which is about his sleep. Any other questions?
Just one question.
Yes.
So the final appliances, the patient will be wearing that at night, or they're wearing that during the day? The mandibular advancement.
Repeat the question.
Okay, he's asking what the final appliance will be. All the patients that I treat, kind of regardless of what the chief complaint is, where we reposition the mandible and develop the arches, whatever, do any kind of orthodontics, their retainer, okay, is basically the same appliance we start with. It's a nighttime appliance that advances the mandible. Okay. Certainly, if you've advanced the mandible during treatment and got it into an appropriate place, we really don't advance it much at all in the final appliance. It looks the same, but the position is different. It's just support because, hey, the whole rest of the body has got to adapt to all these changes. We want to make sure we maintain that open airway. I don't know how long on average it takes all the ligaments and muscles and everything to totally adapt, but everybody gets that for, I tell them, you wear that for 1 year after treatment, and then we start a phase out program if you want. I find typically my more elderly patients say, hey, it feels good, I sleep really well with it, they just wear it indefinitely. Younger ones, it'd be nice to kind of wean them off of it eventually, and that's our game plan. Okay. Any other questions?
Question here?
Yes.
When you're using the alpha or any kind of expansion, how often do you come into a situation where you actually create a crossbite because you've expanded the, right? Like you mentioned earlier, getting the arches to match is a difficult thing. Right? So how often do you find that you need to expand both and then you expand into the maximum?
The question was, can one create a crossbite when you're doing expansion with an alpha appliance, or how often do you have to adjust or accommodate for that? Again, when I have an alpha appliance on the upper arch, okay, just the wire appliance, and an omni on the lower arch, the omni is again half alpha, half orthotic. Okay, so if I'm arch developing up top, okay, I'm arch developing on the bottom to keep those two in sync. So to my knowledge, I've never created a crossbite because I resolve a lot of crossbites. I have a lot of patients that are very narrow, and so you don't always widen them both the same. If you're advancing the mandible, you've already widened the lower arch a little bit. Okay. Yes?
Do most dentists that we would contact know all about these appliances?
Most, okay,
No.
Ask us, wherever you live, ask us to find you something.
okay, the question was, do most dentists know about these appliances? Most dentists probably don't even know how to spell the word temporal mandibular joint, unfortunately. And I'm not trying to put them down for that. Talk to the academicians that are teaching and coming out of dental school. I didn't know anything about orthodontics. I didn't know anything about TMJ, except that you're supposed to shove the jaw back, which of course we've now found. And you're going to see primarily 90% of the orthodontists that we deal with are still using headgear and extracting teeth. My patients have a perception that they're not doing that so much anymore, but I find it still pretty commonplace. So we've got a lot of work to do. As Charles was saying, that's why we need to do the research. Yes?
Is there a dental organization that kind
Yeah, yeah, we'll address that somewhere. Okay, anything else?
We'll have more questions after. Dr.
My time's
Serola?
up.
If you get a chance, you may want to go to there's a website called the TMD Alliance. It's SOTO-USA is the only chiropractic organization that's a member of it. I'm good. And those dental organizations tend to be more in line with what Dr. Johnson and Dr. Shirazi are speaking about, though the use of the alpha is still state of the art in a lot of these practices. And it's tmdalliance.com.